او تتحط على موقع الجمعيه زي ما انتم عاوزين، وبعد اسبوع بتكون موجوده على الموقع بتاعي انا اللي هو متسجل قصاد حضراتكم دلوقتي، اللي هو ssregypt.com. زي ما حضراتكم عارفين ان الماسز الموجوده في الشيست بصفه عامه بتندرج تحت 4 ايتم: البلمونري ماسز والميدياستاينال ماسز والبلورال ماسز والتشيست وول ماسز. واحده من الاساسيات في التشخيص ان انا اصلا اعرف مكان الليجن. يعني لو انا قلت ده بالمونري وهو ميدياستاينال هدخل في السكه غلط، لو انا قلت ان هو شيست وول وهو بلورا هدخل في السكه تانية. وبالتالي واحده من اللي انا هحاول اجتهد ان احنا تلوكالايز دلوقتي هو مكان الليجن. هنبتدي الاول بالبلمونري ماسز، وتعريف الماس بصفه عامه هي well defined lesion اكتر من 3 سم، والديفينيشن معناها ان انا ممكن الف حوالين الليجن بالقلم all in all، يعني المارجنز بتاعته بالنسبه لي بتعتبر واضحه. يمكن حضراتكم عارفين انا دايما بتكلم في الحاجات الكومن وما بحبش اخوض كتير قوي في الحاجات اللي هي رير وممكن تتشاف يعني على فترات متباعده، وانا وحضراتكم مش هنعرفها وهنلجأ في الاخر الى المنظار او البيوبسي. كلمة كومن بالنسبة لي بتعني إن الليجن دوت بيتشاف على الأقل مرة واحدة في السنة. ده الكومن بالنسبة لي، إن أنا بشوف الليجن دوت مرة واحدة في السنة، يبقى الليجن ده فريكوينت، الليجن ده وإفري ناو أند ذن هلاقيه، إذا أهتم بالديفرنشال دايجنوز بتاعه. فأنا عندي 3 ماسز في اللنج انسايد ذا لنج بيتشافوا بهذه الفريكونسي. أول واحدة فيهم وأشهر واحدة هي البرونكوجينيك كارسينوما، وبعدين الميتاستاسيس، وبعدين الهايداتد سيست. كلنا عارفين ان التفرقه ما بين الثلاثه دول سهله جدا بالسي تي، بان انا لو عملت السي تي وطلع الكوره اللي انا شايفها هنا في البرين اكس راي جواها ميه يعني فيها فلويد density، then I am dealing with hydatid cyst which is the only mass inside the lung filled with fluid. مع احترامي لكل الآراء وإن الخراج بيعمل كده وإن لكن if you know إن الخراج لما يكبر لحد 3 سم it should contain air، ولازم يكون في air fluid level، وساعتها ما بيكونش ماس ولكن بيتحول إلى cavitary lesion. إذا if I do a CT scan and I see a lesion which عنده الكرايتيريا بتاعت الماس ويحتوي على مية، then I am dealing with hydatid cyst most likely. But if you have the mass like this and you did the CT scan and you see that the mass is solid, then you are in the 2 possibilities اللي هما الكارسينوما and the metastasis. الميتاستاتيك deposits are diagnosed by multiplicity أو by the known history of primary malignancy. If you don't have positive history of primary malignancy and the lesion is solitary, then you are dealing most likely with the bronchogenic carcinoma. ومن هنا بيجي شبه قاعده كده ان هي الماس السوليد الموجوده في اللنج بتاعه الادلت should be considered as a bronchogenic carcinoma until proved otherwise. سواء you proved the solid nature of the region by CT او by MRI، وانا شايف ان الCT is more reasonable في معظم الاحيان، الا لو كنت محتاج حاجه معينه السي تي ما يعرفش يعملها زي vascular invasion او mediastinal invasion. And this is a mass in the upper part of the left lung, and by MRI T1 weighted images and T2 weighted images the mass is solid and you consider the possibility of bronchogenic carcinoma. من مميزات الام ار ان can have the sagittal and the coronal images اللي هي بتدي لك better orientation of the lesion. Then if you see a mass like this and that the mass is adjacent to the chest wall, and you should يعني تبص كويس جدا على الريبس. This is one of the important findings in assessment of a bronchogenic carcinoma, and the CT scan showed that the mass is solid, there is no rib destruction adjacent it, but the CT showed an important finding which is the lymph nodes in the mediastinum, and this is the prevascular lymph node and also lymph nodes in the precarinal area. Then you are dealing definitely with a malignant lesion which is bronchogenic carcinoma. And this is a lesion in the chest X-ray. It looks like a consolidation, but in the CT scan it is a real mass there is no air bronchogram inside, and that the texture of the region is not that of the consolidation of the lung, then you are dealing with the bronchogenic carcinoma. And this is another example. You see a mass in the upper part of the right lung, and the mass is solid by CT, but the patient is known to have renal cell carcinoma, then you are dealing with a metastatic disease. And if you see multiple lesions in the plain X-ray, you should think of metastasis. This is a large lesion, and there are 2 other lesions in the lung. This is very important to guide you about the possibility of metastasis. But if you see lesions like this, and they are numerous, ranging in between nodules and masses, and without thinking of a known primary malignancy, we should consider this as metastasis until proved otherwise. Then look at this example, and you see here there is a lesion in the lung which looks like if it is containing fluid. But a careful observation here is to look at the superior vena cava, and you see inside the superior vena cava there is a lesion which is of similar density to the original one, and the rest of the exam showed that this lesion is continuous, reaching the right atrium, and this is a tumor thrombus. The patient is known to have liposarcoma of the thigh, and these are metastases containing fat, and that's why they are of low density, similar to the fluid. But in this child, and you see he is known to have osteosarcoma. There is a very big mass on the right side, diagnostic of metastasis. Also, this patient is having a carcinoma in the colon, then you should consider all these as metastasis. If you don't know the history, you should also consider these findings as metastatic deposits. Then if you have 2 or more lesions in the lung, there is a possibility that these lesions may represent hydatid cysts, because you know that hydatid can be multiple. But you should think of metastasis first, because metastases are far, far, far common compared to multiple hydatid cysts. Then you have a CT scan and you realize that you have water density in both lesions, then you are dealing with hydatid cysts. Then don't think of these lesions as hydatid cysts as a first possibility. You should think of metastasis. But if you have the CT scan and you see that all the lesions are containing fluid, then you are dealing with multiple hydatid cysts. Can you predict the nature of hydatid cysts from the plain X-ray? Yes. And if you have one of 2 findings. The first one is you see an intact hydatid cyst and a ruptured one. And you see this cavity with a small air fluid level in its dependent part, and this is ruptured hydatid cyst. If you see multiple lesions and one of them is containing air fluid level, then you are dealing definitely with hydatid cyst, because this is a ruptured one and these lesions are intact one. A very well-known imaging finding is the detection of air in the wall of the mass. If you see air in the wall of the mass, and this is not found in the bronchogenic carcinoma nor in the metastasis, then you know that you are dealing with hydatid cysts from the plain X-ray. And this is an example by MRI. You do not usually need MRI here, but you see an intact hydatid cyst, 2 hydatid cysts in the right lung containing fluid, and the fluid is bright in the T2 weighted image, and this hydatid cyst is ruptured. It contains air, and air is of black signal in all pulse sequences, similar to air in the lung. Also note the presence of hydatid cysts in the dome of the liver. But look at this example. You see 2 masses, and these masses are of certain characters. Number 1, they are in the upper part of the chest. Number 2, they are on either side of the mediastinum. Number 3, and you see reticulations in the rest of the lung, and also you may find some of the pulmonary nodules. Then in the positive history of a patient working in industrial works, for example, then you think of this diagnosis, which is progressive massive fibrosis, which is considered as a spot diagnosis in the radiology practice in the exam. If they put a film like this with 2 big masses on either side of the mediastinum and reticulations of the lung, and you should think of that. But in this female patient, you have two masses on either side of the mediastinum, and you see also a lymph node posterior to the superior vena cava. This patient had breast cancer. Then you know that these masses are metastatic deposits. Then we came to a mass containing air bronchogram. And you see there is a mass, and inside the mass there is air bronchogram. We have three differential diagnoses for this, including round pneumonia, lymphoma, and bronchoalveolar carcinoma. Of course, you can spot the possibility of pneumonia from the clinical picture of the patient, is considering the presence of fever, cough, and expectoration. But the two other lesions cannot be spotted from the plain film. From the CT scan, they need further evaluation by biopsy. And this is an example. This is a female, 20 years old. She had pleuritic chest pain, no fever, no cough, and there is a lesion here in the basal part of the right lung, and this lesion proved to contain air bronchogram, and finally it is proved to be lymphoma. One of the lesions also that has a specific appearances in the CT scan in particular is the presence of a mass with systemic blood supply. Then you see this is the aorta, and you see a vessel coming from the aorta inside the mass. Then you are dealing with definitely a sequestrated lung segment. Then if you see a mass inside a cavity, and you think of aspergilloma or mycetoma or fungal bone, the three names for the same pathology, and this is a classic appearance by X-ray and by CT. But if you see a mass inside a cavity which is malignant, how can you know that the cavity is malignant? By the thickness of the wall and the irregularity of the inner margin. If the cavity is malignant by the thickness of the wall and the irregularity of the inner margin, then the mass inside the cavity is now representing the shreds of the tumor before being expectorated by the patient. Then we came to the mediastinal lesions. How can you predict that this mass is of mediastinal origin? Because this will shift the differential diagnosis. First, you can discriminate between benign and malignant lesions like this. Benign lesions are usually containing fluid like this, and malignant lesions are usually solid. And you know, in each mediastinum, the three parts of the mediastinum, anterior, middle, and posterior, you should have a cyst containing fluid. Anteriorly, the pleuropericardial cyst. In the middle mediastinum, the bronchogenic cyst, and posteriorly, you have the esophageal duplication cyst. Then, how can you know that this mass is inside the mediastinum? Number one, the main bulk of the lesion is in the middle line, because the mediastinum is a middle line structure. Then if you see most of the lesion is in the midline, you may think that this is a mediastinal pathology. Then the mass is arising from one of the mediastinal structures, which are the lymph nodes and vessels. If you see a mass like this one arising from the ascending aorta, this is definitely a mediastinal mass, and this is aneurysm of the ascending aorta. Then you have two weak signs. Number one, the obtuse angle with the mediastinum, and number two, the contact between the lesion and the mediastinal border. This angle is a weak sign, and you see this is a pulmonary lesion. It has a sharp acute angle with the mediastinal border. But if you have a mediastinal mass, and this mass will displace the lung, and you got an obtuse angle at the edge of the lesion, this is not a good, reliable sign. But if you see that the lesion is mostly present inside the mediastinum, in the midline, and you know that this is mediastinal pathology, then the lesion is containing fluid, it is a cyst, and this is a classic case of a bronchogenic cyst. Then look at this example, which is very good. Then you see there is a lesion with a contact of the mediastinum with the mediastinal border more than 5 centimeters. And this is considered by the radiologist as a sign of mediastinal pathology. But what's very important here, if you look here, you may feel that this cyst is in the lung. If you know that, if you decide that this cyst is in the lung, and you are in the diagnosis of high diet. But observe this very, very important sign. And you know the cyst is a benign lesion. It cannot insinuate itself posterior to the superior vena cava. Never. The cyst cannot go inside the mediastinum posterior to the superior vena cava. But if you see this, you know that this lesion arises here in the mediastinum posterior to the superior vena cava. Then because of getting large, it is now simulating as if it is in the lung. And this is also a bronchogenic cyst. And this is also the same sign. You see a cystic lesion insinuating itself in the posterior mediastinum between the heart and the aorta. This cannot be seen in lesions arising inside of the lung, and this is a bronchogenic cyst. Then, apart from the cyst, you have solid masses. In the anterior mediastinum, you have 3 or 4 masses, starting by the letter T. The thyroid masses, the thymic, teratodermoid, and terrible nodes or lymphoma. Then thyroid masses are easy to diagnose by, number 1, displacement of the trachea. And no mass in the superior mediastinum can displace the trachea apart from the thyroid. Then number 2, and you see a good example here with displacement of the trachea to the opposite side, and you can confirm the diagnosis by CT if you see the thyroid masses are hyper-enhancing. They contain iodine, they are dense without contrast. But if you inject contrast, you will show intense enhancement, and you can also see some calcium, and you can also see some nodules which are not enhancing, and this is a nodular goiter, as you can see here. Then one of the anterior mediastinal masses is the teratodermoid, and the teratodermoid is diagnosed first by fat. Then if there is calcium and fluid, well and good, but fat is an essential finding for the diagnosis of teratodermoid. And you see here, this is fluid, this is calcium, and this black areas represent fat. This is a teratodermoid in the anterior mediastinum. If you look here and you see a lesion here, in the lateral view, there is a mass retrosternal, and the mass contains the flecks of calcium, and the CT scan, and you see the calcium, the fat, and the fluid. The fat is a very important sign for the diagnosis of teratoma or teratodermoid in the anterior mediastinum. Then the problematic mass is that of the thymus. If you see a mass here, and this is not thyroid and not teratodermoid, it is either a thymus or a lymphoma from the superior mediastinal lymph nodes. Then thymic tumors are usually solid. They are located at the anatomic site of the thymus. They do not show fat. They do not show enhancement similar to the thyroid gland, and they have no continuation in the neck as the thyroid do. Then look at this case, and you see a mass here, and the aorta is well identified through the mass. Then one of the helpful signs, if you are in doubt, is to get MRI, because MR is able to show the mediastinal fat. And you see here, this is the fat of the mediastinum, which is almost surrounding the lesion. Then you know that this lesion is in the mediastinum, and being in the anterior mediastinum at the anatomic site of the thymus, it is a thymic tumor. When in the sagittal image is also clear. Then thymic tumors can also show calcium, and this is an example, a huge mass here which is projected anteriorly in the lateral view, and the CT scan showed a solid mass containing calcium. You know that bronchogenic carcinoma also contains calcium, and I will discuss the differential between both. And this is a mass in the anterior mediastinum, and look carefully to the superior vena cava, you see a tumor thrombus. Then you know that this is an invasive thymoma or malignant thymoma if it has invaded one of the mediastinal structures. But you also know that one of the common causes of invasion of the superior vena cava is the bronchogenic carcinoma. And this puts us in the differential diagnosis in the mediastinum between bronchogenic carcinoma and the thymic tumors. Lymphoma is a bulky mass made of lymph nodes. It is usually homogeneous. It does not contain calcium. And one of the signs is known as the floating sign. A floating sign is the vessels are floating within the mass itself. And this can help you to discriminate between thymoma, which displaces the vessels, and lymphoma where the vessels can float inside the tumor. And you see here, the vessels are floating within the mass, while with thymoma, the vessels are displaced posteriorly in relation to the mass. And this is the case of lymphoma, Hodgkin disease, with bulky mediastinal lymph nodes. The nodes of lymphoma are bulky, they are homogeneous, they do not contain areas of breakdown, and also they do not contain calcium. And here you see broadening of the mediastinum with lobulated outline suggestive of a lymph node pathology, but the CT scan showed a mass in the anterior mediastinum displacing the vessels posteriorly. Then you may think of lymphoma or thymoma or lymphoma arising from the thymus itself. Then be sure that the masses invading the middle mediastinum are usually coming from the lung, because in the middle mediastinum there are no masses, they are only vessels and lymph nodes. So if you see a lesion like this, and this is the bronchogenic carcinoma which has invaded the mediastinum. The posterior mediastinal lesions are easy to differentiate because they are three: the esophageal lesions and the spinal pathology and the neurogenic tumors. Esophageal lesions are diagnosed by the presence of the esophagus inside the tumor. And you see here, this is a mass with the esophagus inside. And this is also a posterior mediastinal mass with the esophagus containing some gastrografin inside the tumor. And you confirm this by endoscopy or even by barium as well. Then Bot's disease is one of the lesions affecting the vertebrae, with the huge cold abscess in some cases occupying a good part of the mediastinum, and this is a spot diagnosis. But the neurogenic tumors are differentiated according to the age. If you are dealing with a pediatric case, then you are in the sector of neuroblastoma. The neuroblastoma is a mass in the posterior mediastinum. It contains calcium. 85% of neuroblastomas contain calcium. They can invade the spine, and this is one of the criteria. But if in the older patients, and you are in the more mature forms like ganglioneuroma, for example, and this is a good example. This is not a cyst, but it is a solid lesion, and you know that schwannomas in particular look like cystic structures in the CT, and you can see also the flecks of calcium within the lesion. And this is also a case of schwannoma in the posterior mediastinum. You can know its posterior location from the frontal view by the silhouette sign compared to the cardiac border. The lesion is located posteriorly here, and in the CT scan it's also located posteriorly. And this is once more the ganglion. Then we came to the pleural masses, and pleural masses are diagnosed by three main findings. Number one is the presence of nodular pleural thickening. Number two, the presence of ipsilateral pleural effusion. Most of the pleural masses are usually unilateral. Putting on the top of these lesions is the mesothelioma. Mesothelioma is a mass encasing the lung, infiltrating the pleural surfaces, and it is may extend into the mediastinal pleura, may affect also the fissures, the pleura in the fissures. Then if you see a mass like this, and you see the lung inside the mass itself, then you know that this is a pleural mass, and on top of the differential diagnosis is mesothelioma. But if you see a white hemithorax, and you know that this is massive effusion, then you should have a CT scan to know what is underlying this effusion. And here you can see that there is a big collection, and the collection is surrounded by pleura. The pleura showed nodular masses and also calcium, and this was a case of mesothelioma. And this is also a case of mesothelioma where you can see diffuse non-uniform thickening of the pleura on the left side, and you can see multiple mediastinal lymphadenopathies. If you see the bilateral pleural pathology, then think of metastasis. And mesothelioma is rarely to be bilateral. Then you see here multiple nodular masses on the left and on the right, and this patient had renal cell carcinoma. These are pleural metastases. And this patient had thyroid cancer, and you can see the nodular appearance from the plate film, and you can confirm this by CT. And you see here the non-uniform nodular pleural thickening bilaterally. And if in cases of bilateral disease, think of metastasis. Then what are the features suggesting malignant pleural disease? Number one, circumferential pleural thickening. Number two, nodules, pleural nodularity. The thickening should be greater than 1 centimeter to exclude inflammatory pathology. Then involvement of the mediastinal pleura is one of the supportive criteria. Also, pleural lymphoma can show bilateral disease, but you cannot reach the diagnosis unless you have a biopsy or you know that the patient had lymphoma. Then if you see a chest wall mass that is central to the chest wall, meaning that the part inside the chest equals the part outside the chest, then you most likely, if this mass is solid, you are dealing with metastatic disease. It's better if you know that the patient had a primary malignancy, then you are in the right way of the diagnosis. And in this case, you see there is a breast implant, meaning that there is radical mastectomy, then you know that this mass centered to the chest wall with destruction of the rib is diagnostic of metastasis. One of the common primary lesions of the chest wall is chondrosarcoma. And chondrosarcoma can be seen in the pediatric age, can be also seen in adult population. Then if you see a malignant mass with rib destruction containing calcium, and calcium is one of the prominent features of chondrosarcoma. But if the patient age is young, like this female patient, and put in the differential diagnosis Ewing sarcoma of the chest wall, and this is an example of an Ewing sarcoma, and this is also an example of Ewing sarcoma destroying the rib with a large intrathoracic component and a smaller extrathoracic component. And this is a good example of chondrosarcoma of the chest wall, and you can easily appreciate the matrix calcification of the lesion. Some of the tumors in the lung, like bronchogenic carcinoma and mesothelioma, can invade the chest wall. And this is an example of a bronchogenic carcinoma invading the chest wall. There are two signs of chest wall invasion. Number one, rib destruction. Number two, tumor extension beyond the margins of the chest wall. And this is also a case of bronchogenic carcinoma with a chest wall invasion underneath the pectoralis major. And one of the common lesions that are almost infiltrating the chest wall is the Bankus tumor, which is located at the apex of the lung. You can appreciate invasion of the chest wall from the plain X-ray by rib destruction, and by CT you can see that the mass has extending beyond the confinement of the chest wall, infiltrating the muscles outside the chest. But you should know that one of the most important imaging modalities for evaluation of Bankus tumor is MRI, especially in the sagittal image like this, because the surgeon needs to know what about the subclavian artery, the subclavian vein, and the brachial plexus. If these lesions are infiltrated by the tumor, no rule for surgery. But this is the only way to get this information. It is from the sagittal MRI of the chest. Then you cannot appreciate invasion of the chest wall from the plain X-ray in a case of mesothelioma infiltrating the pleura, and it has invaded the chest wall with rib destruction as well. Then the chest wall masses, if they are central to the chest wall, and usually they are solid, consider metastatic deposits. Rarely you got myeloma, which is an easy diagnosis if you see expansion of the rib, and also you may get lymphoma of the chest wall, and in this case you need the help of biopsy. Also, you know that chest wall can be invaded by bronchogenic carcinoma and mesothelioma. The last example in my talk is this very important lesion, and it is just a benign, incidentally found lesion, which is usually bilateral, found in old women, and this is what's known as elastofibroma dorsi. This lesion is made of fibrous tissue, muscle, and fat. It's a classic appearance in the CT scan and also in MRI, obviates the need for further evaluation. I say that because some of these cases are referred to me for CT-guided needle biopsy, and I say that there is no need for biopsy. This is classic appearance of the lesion, which is benign and needs no further evaluation. And I thank you very much.